Rajagopal.
Sir? Sir?
Sir, Kumaran sir.
Yes, sir. Yes, sir.
Yes, sir.
Hello, sir.
So the program is live in YouTube, sir.
Yes, sir. So we'll ask ma'am to start. Ma'am.
Sir, opening that.
Ma'am, now the program is live, ma'am.
You could start?
Yes, ma'am. So we have one of our students. She will introduce the program, and so we can start. Kavya, is there?
Sir.
Yeah, please, Kavya.
Good afternoon, one and all gathered here. On this pleasant day, I would like to welcome you to all the national webinar on oxygen delivery guidelines for nurses, health technicians, staff, and professionals. It is our humble request to the participants to raise hand in case of any doubts and mute themselves. And we are glad to have the participants from various regions. Now, I would like to invite Dr. Kumaran Shanmugam sir, an associate professor and dean research, to share his views and words. Over to you, sir.
Okay, thank you, Kavya, for introducing me. So just I have 2 slides, and I will take less than a minute. So this is a part of a Innovation Council. It's a Ministry of Education and All India Council of Technical Education. Part of the program we are conducting this. As probably knows, the Institution Innovation Council. It's there in all the leading, in all the technical institutions, as well as in the arts and science institution. The idea is to have innovation among the students, IPR, startup, and the entrepreneurship. These are the 4 pillars. We should take it to the students and the faculty members to that. So that's why we have received 5 stars. We are one among the institutions in India to receive that. The second is the program is also when okay. This is a program which Gulf Engineering is from India. They have one of the leading companies in oxygen generators. So I would like to now, this is an introduction which I would like to give to you, all the participants, and thank you, Kavya. So please, Kavya.
Thank you so much, sir, for such valuable words. Now, I would like to give a brief introduction to our honorable resource person, Dr. Kanmani Bharthasarathy ma'am. She is an Australian citizen born in Pondicherry and one who completed her PhD in nursing and being a trainer, assessor, as well as an interpreter in Australia. She is well known for her research works and also her experience in health and community programs and education. It is our huge opportunity to have you here, ma'am, and we are glad to have you here. Over to you, ma'am. Now the stage is.
Thank you. Kumaran sir, could you allow me to share my PowerPoints?
Yes, ma'am. Sir, could you give the ma'am the permission? Okay, I can also do it. Yes, ma'am. We have to make the permission. Just a moment. Sir, are you there, ma'am?
Sir.
We want Dr. Kanmani Bharthasarathy to be co-host, so she can put the slides.
Sir, madam can share the slides, sir.
Yes, thank you, sir. Ma'am, could you try now?
Yes.
Yeah.
Never forgot the first time when I was administered oxygen therapy to a client during my clinical practice using nasal cannula with limited infrastructures and equipment, which is before Google in 1997. But currently we are in technology world. The year 2020 was made the whole world a dramatic change. Breathing device or used to support the patients who have acute respiration problem due to pneumonia associated diseases like COVID-19, asthma, and dry coughing. The most used devices which are utilized for COVID-19 treatment are oxygen therapy device. So by end of this topic, you could able to know why oxygen is essential, what are its types and various methods of administrations, and what are its complications, its assessment, and how to document it in clinical setups, assessment, nursing, diagnosis, all. Before getting into topic, I would like to introduce few definitions which you are already familiar with. So the partial pressure of carbon dioxide in atrial blood, it is used to assess the adequacy of ventilations, which is PaCO2. And PaO2, you all already know, as I told, the partial pressure of oxygen in atrial blood, it is used to assess the adequacy of oxygen. The SpO2, which is the common term we all use, the atrial oxygen saturations measured by a pulse oximeter. The humidifications is the additional of heat and moisture to a gas. The most common usable other terms is hypoxemia and hypoxia. Whereas hypoxemia is the low atrial oxygen tensions in the blood. Hypoxia is the low oxygen level at the tissues. Minute ventilations. The minute ventilations is calculated by multiplying the tidal volume by the respirations rate measured in the literature per minute. It is the minute ventilations. Usually this will be helpful in ventilators. And the other common thing you should know is the tidal volume, the amount of gas that moves in and out of the lungs with each breath, and it is measured in millimeters. Next, we will see few abbreviations when we're using oxygens. These things you should be very familiar with. Certain things you already know, which is the air, nasal cannula, and the venturi mask. This venturi mask are of various percentages. This depends upon the amount of oxygen delivered. Humidified O2, which is in short H28, and RM reservoir mask. Cpap, the common term we all know, continuous positive airway pressures, non-invasive ventilations, simple face mask, tracheostomy mask. So these all things you should be well aware of. I think, sir, now I am the host or the best, because most of the things it's showing me to admit. It's my part to admit them or someone doing there. Because it's like distractions every time, too many candidates getting in and say it's my part, I am only admitting them. It's something changing. Anyway, kindly look into that. Sorry. So, oxygen gas, which is found in the air, is necessary for human life for breathing. While one feels short of breath and the level of oxygen being very low, then supplemented oxygen therapy is needed as a breathing aid. The air we breathe in contains approximately only 21% of oxygen. What are the remaining things? The remaining approximately 78% of nitrogen, 1% of other gases, which includes carbon dioxide, neon, and hydrogen. So why is oxygen essential? This is essential for respiration because the body uses it to burn food molecules. So oxygen therapy is administered at a concentration of pressure generated than that found in the atmosphere. So it is the key treatment in respiratory care. So oxygen therapy is the term we used for clinical use of supplemental oxygen. So its indications in patients with acute hypoxemia and those with symptoms of chronic hypoxemia or increased cardiopulmonary workload. So oxygenation is the process of supplying oxygen to the body cells. For simple, in a healthy adult with healthy lungs, this looks like a patient who is breathing without any signs of distress. Their breathing is unlabored at around 12 to 20 breaths per minute, and you don't see any abnormal signs of increased respiratory effort such as nasal flaring or accessory muscles use. Their skin is normal color for their race with no signs of pallor or cyanosis. They are calm, not showing signs of anxiety, confusion or restlessness. When you listen to their lung sounds are very clear and their voice is clear without signs of hoarseness, and they are able to cough and swallow effectively. In other words, you don't see any imminent risk for airway occlusions due to airway edema or dysphagia. So this is the normal adult. Always, if you're familiar with the normal things, then it's very easy for us to get into the abnormal one. So here are some normal values. So in normal, the SpO2 saturation should be between 94% to 98%. And for adult, the SpO2 should be between 94 to 98. And for infants with bronchiolitis, it is less than 90%. And here the values you all are very familiar with. I am confident with that. Main thing here I would like to say is the difference between hypoxia and hypoxemia. So a lot of times you will hear these terms used interchangeably. Though hypoxia refers to a low oxygen level in the tissues, hypoxia is in hypoxia, the SpO2 is less than 90% as measured by the pulse oximetry, whereas hypoxemia is low oxygen level in atrial blood and it's measured atrially, and its PaO2 level should be below 80 mm of Hg. So it is very important to understand that these two conditions are actually different and do not always occur simultaneously. So a patient can have hypoxemia without hypoxia if the body has had time and the ability to utilize compensatory mechanisms. Conversely, the patients can have hypoxia, which is the low level in the tissue, without hypoxemia, like low level in the blood, if the cells are not able to utilize oxygen effectively. So, as you all know about the values, the expected normal values, if there is any deviations, then you should call the medical emergency team. So, what's the aim of emergency oxygen therapy? Its aim is traditionally administered to stabilize patients who are critically ill. It is to improve tissue perfusion and reduce hypoxemia with the overall goal of preventing tissue and organ damage. Okay, so what will be the indications for the same? So when does a patient need oxygen therapy? There are few signs and symptoms. The treatment of an acute or emergency situations where hypoxemia or hypoxia is suspected And if the child is in respiratory distress manifested by dyspnea, tachypnea, bradypnea, apnea, pallor, cyanosis, lethargy or restlessness, use of accessory muscles, nasal flaring, intercostal or external recession, tracheal tug. So any patients who develops or has an increase in their oxygen requirement must be medically reviewed within 30 minutes. So if you find any abnormalities, you should call the medical emergency team within 30 minutes. That's the keynote here. Oxygen therapy is a standing medical orders for nurses. But anything which is low or high or harmful. So both hypoxemia and hyperoxemia are harmful. So oxygen treatment should be commenced or increased to avoid hypoxemia and should be reduced or ceased to avoid hyperoxemia. So for children receiving oxygen therapy, SpO2 targets will vary according to the age of the child and the clinical conditions and the course of their illness. And another thing, oxygen treatment is usually not necessary unless the SpO2 is less than 92%. That is, do not give oxygen if the SpO2 is equal or more than 92%. And the oxygen therapy may be varied in most circumstances without specific medical orders, but medical orders override these standing orders at times. Again, nurses can initiate oxygen if patients breach expected normal parameters of oxygen saturation. A medical review is required within 30 minutes. So, the following may be undertaken by nurses without medical orders, like when to start or increase oxygen therapy, commencement. So, oxygen therapy should be commenced if the SpO2 is less than 92% if the patients without cyanotic heart diseases. Again, SpO2 is less than 70% in patients with cyanotic heart diseases who have had cardiac surgery. And again, if a patients with cyanotic heart diseases who are waiting for cardiac surgery and their SpO2 is less than 60%, and any level less than 91% in premature and newborn neonates. Persistently, a decreased which is less than 90% for infants with bronchiolitis. Again, when to reduce or stop the oxygen therapy. This should be when SpO2 is equal to or more than 92%. Again, SpO2 is less than more than or equal to 90% for infants with bronchiolitis. And again, cyanotic heart diseases reaches their baseline of SpO2. As I continuously repeats, everyone, I want to be familiar with your standard values, so it is very easy to rule out the abnormalities. So, what are the assessments, patient assessment and documentations? So, assess the airway and optimize airway position, the usual positions, head tilt, chin lift as necessary. Again, clinical assessment and documentations including but not limited to cardiovascular, respiratory, neurological systems should be done at the commencement of each shift and with any changes in patient's conditions. Check and document oxygen equipment setup at the commencement of each shift and with any changes in patient's conditions. Hourly checks should be made for oxygen flow rate, patency of tubing, humidifier settings if being used. And again, Harley checks should be made and recorded on the patient's observation chart for their heart rate, respiratory distress, whether the client using any accessory muscles, nasal flaring, and their oxygen saturations. Continuous pulse oximeter is recommended for patients who are severely unwell and who are likely to have rapid and clinically significant drop in oxygen saturations when the oxygen therapy is discontinued. Continuous pulse oximeter may not be necessary in the client who is stable, still receiving oxygen therapies. So, as I told, in case of any deviations, you need to call the emergency team. So, this is what we discussed now. So, the criteria when to call medical emergency team. So, if the respiratory rate is less than 5 or more than 35 breaths per minute, and their pulse rate less than 40 or more than 140 beats per minute, and if there is a sudden fall in level of consciousness or reported or prolonged seizure, and any patients who you're seriously worried about and does not fit the above criteria. If you find the client is not having the normal values and if you're worried, call the emergency team, don't wait. So, how is oxygen provided? In hospitals, as you all aware, oxygen cylinder, wall outlet, oxygen flow meter, etc. So here, the oxygen flow meter should be all aware of, where the center of the ball indicates the correct flow rate. The ball must be centered on the line. This diagram illustrates the correct setting of the flow meter to deliver a flow of 2 liters per minute. You can able to see the ball's correct, the ball's readings, the line should be the middle and it shows 2 liters of oxygen per minute. And here another thing I want to know is, again, aware of this outlet. See, the oxygen outlet is usually white in color and the air outlet is usually black. So this you should be aware when you administering the right valve for oxygen when you're connecting your catheter to the client. And then next, at home, we use oxygen concentrators, compressed oxygens, liquid oxygen cylinders. At home, these instruments are mostly presetted, so nothing harm in its delivery, but be aware of complications like hazards, especially fire, that you should be very careful when you're using at home. And next, we will see oxygen monitoring, how you are going to monitoring. Everyone is very familiar with this pulse oximeter. So, is a device that is usually placed on your index or middle finger tip for at least a minute till the reading stabilizes. So, always record the highest reading that flashes on the oximeter after it has been established. We can use finger, toe, sometimes earlobe of a patient, and this is the widely used non-invasive and it is simultaneously assessed of hemoglobin oxygen saturations. And if this instrument uses light beams to estimate the oxygen saturations of the blood and the pulse rate, oxygen saturations gives information about the amount of oxygen carried in the blood, the red blood cells. Again, the normal value is 94 to 100%. They are reliable, accurate, and relatively inexpensive and portable. And again, pulse oximeters are often used for estimating heart rate at rest and during exercises. Hazards here, if it is incorrect readings, if the probe falls off the earlobe, toes or fingers, again, skin irritations from adhesives on the probe. And next we will see for children. So a small portable oximeter probe suitable for the use of fingers or toes for child. In neonates and infants, probes may also be placed on the palm, feet, arm, cheeks, tongue, penis, nose or nasal septum. Again, a small portable pulse oximetry probe can be applied to patients of any size, from premature neonates to the largest adult. And again, once the probe is on the, on children's fingers or in the toes, you have to check for the skin under the probe and change its site every 4 hours or more often if needed. And it's again in non-invasive and painless. It usually does not hurt the child. Hazards usually if the probe falls off, there will be an incorrect reading, and due to the plasters, they have skin irritations. So oxygen is administered to broad ways. One is low flow delivery method and other is high flow delivery method. Low flow is usually contribute partially to inspired gas try breaths. Example, nasal cannula, simple mask, non-rebreather mask, partial rebreather mask. High flow usually specific percentage of oxygen independent of client's breathing. Example, ventilators, venturi mask, truck collars or the TPs. Now we will see the methods of administration. Nasal cannula, this is comfortable and easily tolerated. No rebreathing. Patients can eat and drink. This is the preferred by patients and it's low cost. The flow rate is 1 to 6 liters per minute. This provides oxygen concentrations of 24 to 44%. So I'll give a timetable here so it will be easy. So for nasal cannula, you can have these key messages, the amount delivered, it comes under the low flow, and the interventions, check frequently both the prongs or in client's nose, never deliver more than 2 to 6 liters per minute to client with chronic lung diseases. So the standard amount of flow is 1 to 6 liters, but in case of a client with chronic lung diseases, it should be reduced between 2 to 3 liters. And the advantages, clients able to talk and eat with oxygen in place, and it's easily used in home settings also. The disadvantages is again always irritations, nasal pharyngeal mucosa, and if oxygen flow rates are above 6 liters, there will be variation in fractions of inhalations of oxygen. So this should be always monitored. And then Nasopharyngeal Catheter. So this catheter is inserted in one nostril with the end of the catheter resting in the oropharynx. So remove and clean and change to other nostril every 12 to 24 hours. Don't leave at one nest for a long time. Maximum is 12 hours enough. And this comes under the low flow rate. The main hazards is complications from airway suctioning are relatively uncommon if performed with care and adequate pre-oxygenations. Suction can stimulate the vagal nerve, predisposing the patients to bradycardia and hypoxemia. Again, hypoxia can be profound from occlusion, interruptions of oxygen supply, and prolonged suctioning. So here is it. Next, we will see mask. So there are 4 types of mask which we are using: simple face mask, partial, and non-rebreather, and venturi mask. We will see one after the another. So simple face mask. The minimum flow rate through any face mask is 4 liters per minute, as this prevents the possibility of carbon dioxide accumulations and carbon dioxide rebreathing. So always select a mask which best fits for the child's bridge of nose to the cleft of the jaw, and adjust the nose clip and head strap to secure in place. So oxygen via a face mask at flow rate of 4 liters per minute does not routinely require humidification. However, as compressed gas is drying and may damage the tracheal mucosa, humidifications might be indicated appropriate for clients with thickened secretions or secretions retention, or for generalized discomfort and compliance. So here is a table. So simple mask, the flow rate, nursing interventions, support client if claustrophobia is concerned, and secure physician order to replace mask with nasal cannula during mealtime. Advantages: can provide increased delivery of oxygen for short period of time, and disadvantages like tight seal requires deliver higher concentrations, difficult to keep mask in positions over nose and mouth, potential for skin breakdown, wasting, uncomfortable for patients while eating or talking, expensive with nasal tubes. Next, partial rebreather mask. So this mask allows you to breathe a mix of pure oxygen combined with your breath for a lower and variable amount of oxygen. So a partial rebreather mask typically delivers 50 to 70% oxygen. They are useful in situations when people have extremely low level of blood in the oxygen, since they can quickly deliver oxygen to your blood. So a partial rebreather mask looks similar to a non-rebreather mask, but contains a two-way valve between the mask and the reservoir bag. So the picture explains clearly. And this is the timetable, which shows the advantages and disadvantages. Advantages is patients can inhale room air through opening in mask if oxygen supply is briefly interrupted. And disadvantages is not as drying to mucous membranes, requires tight seal, eating and talking difficult and uncomfortable. Next, we will see non-rebreathing mask. So a non-rebreathing face mask has an oxygen reservoir bag and one-way valve system, which prevents exhaled gases mixing with fresh gas flow. So the non-rebreathing mask system may also have a valve on the side ports of the mask, which prevents entertainment of room air into the mask. So these masks are not commonly used, but a non-rebreathing mask can provide higher concentrations of fraction of inspired oxygen, FiO2, more than 60%, then is able to provide it with the standard face mask. A standard face mask will provide only approximately 40% to 50%, whereas this mask is able to provide more than 60%. And considering using a non-rebreathing face mask, sure, to ensure the highest concentration of oxygen is delivered to the patient. Also, this ensures the flow rate from the wall of the mask is adequate to maintain a fully inflated reservoir bag during the whole respiratory cycle, that is the inspirations and expirations. So a non-rebreathing face mask are not designed to allow added humidifications. So not routinely used outside emergency department and PICU, and should only be used in consultations with the medical team. And next we will see. So this chart shows the nursing interventions, what to follow, the flow rate of reservoir bags only slightly during inspirations, and always check for the valves. Monitor SaO2 with pulse oximeter. Advantages is delivers the highest possible oxygen concentrations and suitable for patients breathing spontaneous with severe hypoxemia. Again, some disadvantages like suffocations. It's very expensive, feeling of suffocations, uncomfortable. It's very costly too. Ventral mask. So this is also called as a fixed performance mask. So the aim is to deliver constant amount of oxygen concentrations within and between breaths. So the minimum oxygen flow is 4 to 10 liters per minute. With tachypnea, the oxygen flow should be increased by 50%. So increasing flow does not increases oxygen concentration, but it is a fixed dose device. So good device for patients with the raised carbon dioxide can use this, and different colors delivered at different rates, flow rates. So the flow rates, it's various with the colors. The correct flow rate to use with each color, it is shown on mask along with the percentage of oxygen delivered. So this various colors delivered different percentage of oxygen concentrations. And yes, for nursing interventions, it requires careful monitoring to verify fraction of inspired carbon dioxide at flow rate ordered, and again check that air intake valves are not blocked. Advantages: this delivers most precise oxygen concentrations, doesn't drive mucous membrane. And disadvantages: and uncomfortable and risk for skin irritations. It produces respiratory depressions in COPD patients with high oxygen concentrations. And next, TPs. Those who are working with ventilators are well familiar with this TPs, I think. The ability to breathe spontaneously can be assessed with a spontaneous breathing trial using a T-tube or TPs. So these TPs are increasingly used for administering intermittent positive pressure ventilations during neonatal resuscitation. Also, this using as a weaning. When a client removed from the ventilator for weaning, they can use this. So they can also be used to provide free flow oxygen to babies who are breathing but remain cyanosed. And next we will see tracheostomy mask. So this is used for again removing patients from a ventilator, a practice known as weaning. A tracheostomy collar which is placed over a breathing tube in a tracheostomy, incisions in the throat, and through which humidified oxygen is given. So these masks are specially designed to be placed over the tracheostoma and secure around the neck. The mask is connected to an oxygen reservoir with the help of an oxygen tube. So, next, oxygen therapy for children. So oxy hood or oxy tube or tent is a plastic enclosure that surrounds the head of the neonate or the body of an older child, to which a continuous flow of humidified oxygen is supplied by means of an air entertainment device or an air oxygen blender. So this is used for babies who can breathe on their own but still needs extra oxygen. So for 2 years of age children, the flow rate will be 4 liters per minute. Children's over 2 years, 6 liters per minute. And for adolescent children, it's 10 liters per minute and depends upon their weight, more than 30 kg. So a standard pediatric oxygen mask placed on the chest can give significant oxygen therapy with minimal distress to the patient. Nebulizers should be delivered via oxygen but not the air. Next, we will see the Cpap. So continuous positive airway pressure, which is the Cpap. This is well-known device that is used for breathing assistance for the treatment of patient having a mild respiratory problem. The positive airway pressure is delivered through a tight face or nasal mask in Cpap device. The main advantage of Cpap device is that it can deliver positive pressure in each cycle of respiration. The pressure facilitates the alveoli to remain open during the breathing out of a patient. That is very helpful for oxygenation and easy breathing. So this device is a proper suited for the patients having pneumonia related problems like COVID-19 for initial treatment. And next we will see hyperbaric oxygen therapy is a type of oxygen serving device in which patients are entered in a special chamber or a room to breathe in 100% oxygen in their pressure. The target of this device is to repair and restore normal body functioning by filling the blood with adequate oxygen. So the chamber usually looks like a large room in the hospital where a patient can sit down or lie down. In this case, the oxygen is normally supplied with a thin, transparent hood. Though this therapy is normally a safe procedure, it carries some risk. In certain situations, fire may trigger due to the oxygen-rich atmosphere in the treatment chamber. And again, in addition, a lung may collapse due to certain changes in air pressures. Okay, as of now, we saw oxygen methods. Now we will get into oxygen toxicity. So, oxygen toxicity is lung damage that happens from breathing in too much extra supplemental oxygen. As we already saw, anything which is too much or too low is dangerous. So here toxicity results if we breathe in too much extra supplemental oxygen. So it's also called oxygen poisoning. It can cause coughing and trouble breathing. In severe cases, it can even cause death. So be aware of too much supplemental oxygen. So as mentioned, it should not be not more than 50% should be administered for an extended period of less than 48 hours. So potential complications. CO2 necrosis. So this occurs if patients who have chronic respiratory obstructions or respiratory insufficiency, which results in hypercapnia, that is raised PaCO2. In these patients, the respiratory center relies on hypoxemia to maintain adequate ventilations. So if these patients are given oxygen, This can reduce their respiratory drive, causing respiratory depression and a further rise in PaCO2. So always monitor of SpO2 or SaO2 in forms of oxygenation only. Therefore, beware of the use of high fraction inspired oxygen in the presence of reduced minute ventilation. Lung damage. Oxygen toxicity caused by excessive or inappropriate supplemental oxygen can cause severe damage to the lungs and other organ systems. So high concentrations of oxygen over a long period of time can increase free radical formation, leading to damaged membranes, proteins, and cell structures in the lungs. Pulmonary oxygen toxicity. This is a high concentrations of oxygen, which is more than 60%, may damage the alveolar membrane when inhaled for more than 48 hours, resulting in pathological lung changes. Retinopathy of prematurity, ROP. This is an alterations of the normal retinal vascular development, mainly affecting the premature neonates who are less than 32 weeks gestation, which can lead to visual impairment and blindness. And substernal pain due characterized by difficulty in breathing and pain within the chest occurring when breathing elevated pressure of oxygen for extended period. Infections, usually bacterial cross infections, irritations and skin breakdowns. Again, fire safety. This is very common. Oxygen is a combustible and can cause fire. So always notify fire departments, avoid oils, petroleum jellies, use with cautions around other heat sources, and store cylinders and other storage device safely. Next, we will see oxygen safety. So, as we all know, oxygen is not a flammable gas, but it does support combustion. So, due to this, the following rules should be followed, like do not smoke in the vicinity of oxygen equipments, and do not use aerosol sprays in the same room as the oxygen equipment, and turn off oxygen immediately when not in use. Oxygen is heavier than air and will pull in fabric materials, the material more flammable. Therefore, never leave the nasal prongs or mask under or on the bed covering or cushions while the oxygen is being supplied. And oxygen cylinders should be secured safely to avoid injury. Do not store oxygen cylinders in hot places. Keep the oxygen equipment out of reach of children. Do not use any petroleum products. Oxygen is reduced in the supine positions. So always hypoxic patients should be placed in an upright position unless contraindicated. And oxygen therapy can be a life-saving, but nurses must know how it works, when to use it, and how to correctly assess and evaluate a patient's treatment. As I always say, nurses can initiate oxygen if patients breach expected normal parameters of oxygen saturation, and a medical review is required within 30 minutes. Next, we will see assessment. So, what are the assessment? So, assessment of client own oxygen therapy includes a few things. First, in the skin, when oxygen therapy is used by a client, the patient's skin, where the oxygen device comes into the contact with the patient, the nose, the chin, the ear may have skin breakdown due to the irritations of the tubing on the skin. So oxygen therapy tends to cause drying effects to the nares and mouth. Regarding lab results, atrial blood gas, ABG. These results are often obtained for patients who have deteriorating or unstable respiratory status. Again, a blood gas test to measure the level of oxygen in the blood accurately. This is obtained from either a small prick on the ear or blood taken from an artery in the wrist. It is different from the blood test that is normally taken in the arm. That's the keynote here. So performing walking test to examine if the blood oxygen decreases on exertion. Under complications, fluid buildup, rupture of the middle ear, sinus damage, changes in vision causing nearsightedness or myopia. Again, oxygen poisoning, which can cause lung failure, fluid in the lungs, or sometimes ends with seizure. And then documentations. So this is the nursing part. Client documentations is very important. So when starting oxygen therapy in patients who are acutely ill, ensure pulse oximeter is available to monitor response to oxygen therapy. Document baseline observations including saturations, respiratory rate, blood pressure, and pulse. Note respiratory effort, color, level of consciousness. Check there is a prescriptions for oxygen with a stated target saturation range. Ensure delivery devices connected via tubing to oxygen supply and turn on to the appropriate flow rate. If cylinder, check fill level of cylinder and be aware of duration time. Explain procedure to the patient and gain consent where possible. In patients who are acutely sick, this may not be possible, and clinicians should act in the patient's best interest. Place the oxygen mask on the patient's face, adjusting the nose clip and elastic straps to ensure a closed fit. Reassure the patient if the patient is very breathless. Oxygen mask can feel very claustrophobic. Monitor response to oxygen therapy, recheck oxygen saturations, vital signs, color, and level of consciousness, and document all adjustments of inspired oxygen. Fraction of inspired oxygen, which is FiO2, with saturations recorded. The key message, what I want to share with you all is hypoxia is an indication that oxygen therapy should be started. If blood oxygen levels are not low, oxygen will not treat breathlessness. A target oxygen saturation range should be prescribed to guide therapy. A lower target saturation range should be prescribed for patients at risk of hypercapnia, and the amount of oxygen received by the patient is depend on the delivery device used. Always ensure appropriate devices selected. Again, medical oxygen is a key treatment for severe pneumonia associated diseases like COVID-19 that highlighted the critical importance of medical oxygen. The most recent developed breathing aid device such as oxygen therapy device, ventilators, and Cpap, oxygen therapy device or an appropriate solutions for the COVID-19 patients generally available in the hospitals as well as ambulance. So these are the possible nursing diagnoses: ineffective airway clearance, impaired gas exchange, ineffective breathing pattern, impaired spontaneous ventilations, dysfunctions, ventilatory weaning responses. Few references, and the Another key message is the target range of SpO2 is 94 to 98 percentage. Always choose mask and flow rate to meet the target range. No blood gases needed when to start the oxygen therapy. Always set up oxygen therapy immediately, and once you started, review with the medical team within 30 minutes. That's it.
Okay, thank you, ma'am. I have a question, ma'am. Could I ask a doubt, ma'am? This is the first time I'm surprising that the nurses or doctors they are using humidifier with oxygen. So humidifier generally it separates hydrogen and OH minus ions. So probably there should be a slight increase in temperature. So is it is it okay? Like it's giving a humidifier fire and oxygen.
Yes, actually, when we are administering oxygen via cylinders in those equipments, humidification is not set up. Humidification is usually set up when you are using ventilators or other Cpap machines. So that machines is always have a built-in setups. So it's adjust automatically as per the requirement how much we are oxygen flow rate of the client. So in that case, we are not, as a nursing part, we are not much able to do any changes with that settings. So it's safe if it is needed.
Thank you, ma'am. So any question from the audience, please raise your hand or you can put your question in the chat box so we can read it to madam.
Yes.
You can put it in the chat box for any questions or doubt or something like that. That's one. It's it's also panel is going on YouTube, so there will be also questions there. Any questions from participants?
Thank you for your participations and your presence for this webinar.
Madam, this is Kumar. I have one question.
Yes.
Actually, there is an oxygen concentrator.
Oxygen?
There is a machine which is for to forcefully send the oxygen to the lungs.
Yes.
It's a BI from PT. So actually, when it is exactly required, this kind of the machine, when the forcefully oxygen is required to send
Portable oxygen, you're asking, is it?
a portable oxygen concentrator. There another one we send the oxygen forcefully to the lungs. I think it's a name called BAPAP machine.
So, as I already told, oxygen is needed only if there is any changes from the normal values. If not, oxygen is not necessary at all for general normal adults. As I told, if you're having any portable machines or anything, it's nowadays due to this COVID, people are much scared of oxygen is required. Oxygen is required, but only when the saturation level is less than 90% of 90%. Until then, supplementary oxygen is not required at all. So, as of you people, any persons at home, if you think we are having suffocations, we are in need of some portable oxygens, no, it's not required. So that's the key message I want to say. As I already told, if the client is with hypoxia or hypoxemia, only if the saturation level is less than 90%, a supplementary oxygen is required. Otherwise, supplementary oxygen not required.
Okay, madam. How this pulse and pressure, BP, both are related. That heartbeat and the pulse.
Yes. If you have pulse oximeter, it shows your heart rate and also oxygen in your blood.
Okay,
Got
pulse.
it?
Okay,
Yeah, the pulse oximeter machine. That machine tells both your heart rate and your oxygen level in your blood.
Okay, actually, I also affected by COVID. That time,
What happened? What's your how you get rid of that? How you suffer? I mean, what's your treatment?
actually, I had taken this what they call the steroid also. So
Steroids.
yeah. Actually, the start with CRP, that's reached around 51 for me it shows. And in lungs it shows 8 point some point it said 8.9 or 8 point like that it said. The CRP level is went up to 51. So how the CRP is regulated, and another one, the pulse, I had the pulse 161 at the time.
Yeah, pulse rate, increased pulse rate, which is bradycardia, it's more. That's what I told. The rate doesn't depends upon the oxygen level. Okay, that's different mechanism. For your oxygen, if your respiratory rate is less than 5 breaths per minute. Okay. So people don't confuse with all your lab values and all your tests. So oxygen when required only if your respiratory rate is less than 5 breaths per minute, and again your heart rate is more, pulse rate is more. That also shows there is a lack of oxygen in your blood, heart pumping, so it efforts more. So actually in the initial stage, as I told, initially if these changes are there, you'll be started only with a minimum flow of oxygen, which is within 4 liters per minute. Once after the medical team, they should conclude with all your results. Then only they can go you for continued positive pressures or which is the Cpap. It depends. So initially, as I told, if you are having your breath rate is reduced or more, and your, as he told, your pulse rate is more, in that case, they should be initially started with some less than 2 liters of oxygen in order to maintain your patency. Then further treatment should be reviewed only with the medical team. We couldn't say with this only, with these two values, we couldn't say, oh, yours affecting, your lungs is totally affected. We couldn't say like that.
Okay, madam. Actually, why did I ask this BPAP machine means, when I struggled to breathe, so they taken me in a van. So that time, when it goes fast, then the air blow when it's fast, then I got some normal breathing. So when the van stopped, I struggled to breathe. So that's why the machine.
So regarding the machines, what you had, I'm not sure. That's out of my scope. Sorry.
Okay. Actually, it shows that when we breathe difficulties, then it sends the oxygen forcibly to the lungs. Like that it shows.
Yes, some possible, yeah. In that case, if you are suffocating more, a possible supplementary oxygen is required. The things, what the message we want to say here is, since you are having more suffocations, it's not like you could administer more oxygen. You have to maintain the level. Initially start with the low level only. Only consulting with the medical team with all your results, then only you can go for the higher level. Otherwise, again, that case you can have relief of your conditions for the moment. Then after you may lead with, as I told, oxygen toxicity and further complications. So that's why we are not advising clients to take anything of their own.
Okay, thank you.
But now due to COVID, people are very scared and everyone is eager to getting portable oxygens and store in their home. It's required, but as I told, without medical team, they are the one to conclude for you. We couldn't, if as I told, if we started by ourselves, it may be a temporary relief, but still sometimes what most of the time it may end with some toxicity. So always be aware of it.
Madam, one more question. Only one question. What is the temperature would be the oxygen when it is entered to inside? I mean, when we breathe, what would be the
Temperatures.
oxygen temperature?
Usually oxygen temperatures, we are not much known of it. Temperature of the oxygen, because in the cylinder, it is, honestly, I have no idea of temperatures.
Because these are the conditions we need for the project. That's what I asked. Okay.
Or what?
For our project is required, so that's what I asked.
You're a medical person or a non-medical?
No, I'm from biotechnology background. Means I'm from biotechnology HOD. Actually, I'm a biotechnology HOD.
Okay.
We are in the project oxygen concentrator for funded project. So regarding that, we need some points. That's what I asked.
Generally, for human administration of oxygen, I'm not sure. But we have general idea, we know the melting point should be this much, the boiling point should be 90%. That's only we are aware. For human oxygen, approximate temperatures, usually the temperatures what we mentioned should be below 54.36 K, I think.
Okay, no.
You will be more accurate than us, but mainly it is 54.36 K,
Okay,
which is minus 21.8 degrees Celsius. Honestly, this is also out of my scope, but for your interest, I'm trying, but you'll be more aware with this, I think.
Okay, no, madam. Other questions are there, so that's what okay, madam. Thank you for.
Thank you, sir. Thank you, ma'am. There is a question from a participant, Mr. Shankar. He's asking whether usage of pressurized oxygen, which inflates lungs, does it reduce the needs of ventilators?
Needs of?
Ventilators. Ventilators, ma'am. I will repeat the question. Usage of pressurized oxygen, which inflates lungs, does it reduce the needs of ventilators? I mean, is it clear?
Of this it will reduce, they are asking?
Yeah, whether it will reduce whether the patient need to go to ventilator later if they are using a pressurized oxygen. That's what he needs.
Actually, see, as I told, oxygen should be delivered in two ways, low flow and high flow. So if a candidates with high flow, usually the high flow machines are ventilators and Cpap only. Usual ordinary oxygen cylinders and this wall mount, we are not allowed to give high level of oxygen. So if a client is under 60% need of oxygen, it's understood they are in ventilations or Cpap.
Thank you.
Am I with your answer?
I think Mr. Shankar, is it clear? One of the participants was asking. Is there any questions from participants? You can put it in the chat box. So the participants also you can use the form. And there is a mistake. Professor Eleverson has said, been appreciated. Well, information regarding the oxygen requirement and its solution. So he said he is appreciated. And okay, there is another question, Madam Margaret Rose. How to rescue? Okay, just a moment, man. I'll wait.
So few common, most of the few questions are same, I think.
Yes.
As I told, when to start oxygen. As I told, if you found the client's saturation level is less than 90, SpO2 is less than 90, then it's the time to start oxygen. And once you started, it should be, the blood gas must be monitored within 1 hour. Then you should know whether to increase the oxygen therapy. Okay. And what else? and when to stop. Again, this is the main basic line that you should be always aware. So when your saturation is 92 and above, then it's the time to stop oxygen. And always, whether you started or stopping, within 30 minutes, medical team should review. It is at home, you couldn't conclude by yourself. If you yourself increasing or decreasing, it will lead to lung damage. Again, oxygen makes lungs problem. Yes, because breathing 100% of oxygen for long period of time can cause changes in the lungs. It's a low level or high level, continuously, because of atmospheric air, what we are breathing, it consists of only 21% of oxygen. If you're having a straight 100% of oxygen continuously, it is harmful. Okay? So this, the key point you should always keep in your mind.
Ma'am, there is a question from Margaret Rose, which I will start. She's asking, in case during administration of oxygen, in case if there is a fire, how to rescue the patients and what to do?
Again, fire safety, evacuation.
I know. If the oxygen is stopped, then if the patient will be in trouble. That's a point.
But still, fire is fire. You have to go for a fire treatment and evacuation, immediate evacuation procedures. What we'll do, for rescue team, or for the fire team, yeah, health safety team, everything. Stopping alone doesn't stop. We have to go for a further fire.
Probably during rescue time, we are going to take the patient out from the hospital to outside. During the time, if there is no oxygen, is it going to affect their life or something?
We can use mask. I mean, what's that? It's there is some mask available. We can simultaneously use that until we shift the client.
That's a point probably is asking. So when shifting, we have to use some mask temporarily to give the oxygen to the patient.
Yes.
Madam Margaret Rose, probably she got the point, I think. Is there any other question from the audience? Otherwise, we can. Okay, I think that's all I think. I think if any other no more questions from audience, then we can go for the vote of thanks. So, Abhrami, are you there?
Yes, ma'am.
Please.
Thank you so much, ma'am, for such a tremendous session. Now we have been familiar with the topics, including the necessity of oxygen supply, therapy, standard percentages that you have mentioned, age criteria, especially for children, and equipment utilization, and also about various types of mask and oxygen toxicity. I hope for sure those guidelines provided by you will be highly essential in both present and future conditions, ma'am. Thank you so much. On the behalf of the Department of Biotechnology, Periyar Maniammai University, once again, I would like to thank our respected resource person, Dr. Kanmani Bharthasarathy, ma'am, for spending her most valuable time and effort with us. I would also like to thank our respected organizers and participants, since this session has been a great eye-opening in all chances. I feel grateful for this good time. Thank you, one and all. Until then, this is Abhirami Ramalingam from 3rd year BTech Biotechnology signing off. Stay home, stay safe.
Thank you. Thank you, ma'am, for your nice presentation, and it's very useful and to save many lives. And it's the first time we are having very technical presentation on oxygen. Thank you, ma'am.
Thank you. Thank you.
Thanks for participating, ma'am.
Thank you.
Thank you, ma'am.
Thank you, madam.
Thank you.
That is Dr. Ashok Kumar. He's a chemical engineer. He's the head of the department, our HOD. So he was trying for a project. So that's why he's asking some technical questions.
They are more familiar than me regarding the concentrations and percentages. We are not that much in deep with the gases. Thank you.
Okay. Thank you very much, ma'am.
Thank you all. I'm
Thank
leaving.
you. Yes, ma'am. Thank you, ma'am. Please, ma'am.
See you all
Thank
in
you.
our next meet. Thank
Yes,
you.
ma'am. We are very happy, ma'am. Thank you.
Thank you.
We can close the meeting. So I start.